Welcome to the IFRS health education videos. Today we're going to talk about urethral strictures for rural surgeons. Men. What are these urethral strictures? As you can see, the normal urethra has a diameter of about 1 centimeter. And when there is a stricture, it narrows down. And as you can see, if this is the entire urethra, it becomes very narrow and there's only a tiny opening through which the urine comes out. And the most common place where the stricture occurs is the bulbar urethra. As you are aware, from the bladder, it comes down and then it curves and goes up. This is the area which is called bulbar urethra, where the curvature of the urethra is there. The strictures most commonly occur in this area. And unfortunately, the most common cause is idiopathic, or nobody knows the reason why it occurs. But then the second most common is what we know is caused by the doctors or healthcare people, which is iatrogenic. Traumatic strictures account for about 15%, and bacterial urethritis, which used to be very common when gonorrhea was common, is about 10%. On the other hand, the strictures can also occur in the penile urethra. And here the iatrogenic causes overtake the infective causes. And both infective and iatrogenic causes form about 80% of the causes. Idiopathic strictures can occur in about 15%. And trauma is very, very rare, forming less than 5%. You might think that it is not an uncommon problem. But in every 1 lakh population or 100,000 population, there'll be about 200 to 1,200 people with strictures. And the incidence obviously increases with age. And why there is so much variance is that because quite a few of the causes are iatrogenic, where we have more medical professionals, the incidence is probably higher. And how do they present? Most of the time, they present only with the poor stream. And unfortunately, what happens is that although the normal diameter is about 1 centimeter, till it reaches about 25% of the original size, there are hardly any symptoms because the muscular contractions of the bladder muscles compensate for it. And one of the ways that you diagnose the stricture is that straining actually improves the stream. And later on, when the stricture becomes very narrow, there could be intermittency. And because of post-void residue and so on, there may be irritative voiding symptoms. But till it reaches about 25% of the original size, it may be asymptomatic too. And why do you need treatment is because very often, since they become symptomatic only towards the end, people present with acute retention, which occurs in about 60% of the people. And because of the back pressure changes and incomplete voiding, it leads to infection. As you can see, the prostate nearby can cause prostatitis. It can also go back and cause epidemiology. And even the back pressure changes can cause hydronephrosis on both sides. And rarely there are periurethral abscess and also the stone formation. So this is the reason why you need to treat the strictures as soon as possible. And diagnostic, the most definitive and best way to diagnose is use the urethroscopy or have a look at it directly with a cystoscope. Earlier, people used to do MCU, put in a contrast and make them pass urine and take X-rays. And then, of course, uroflowmetry will show an obstructive pattern. And how do you treat it? The most common treatment, or probably the best treatment which you can offer, is endoscopic internal urethrotomy, or called EIU in short. Originally, people said that recurrence rate is about 50 to 60%. But this is without self-calibration. So if we combine EIU with self-calibration, then the recurrence rate can, in a long term, reduce to about 20%. And the way to do it, you have to start doing self-calibration with the larger catheter, say 20 French or 18 French. And anytime it's not possible to, or there is difficulty in passing the catheter during self-calibration, you put in a smaller catheter, wait, and then you need to do the procedure again, repeat endoscopic internal ureterotomy, and then continue self-calibration. This way, there's absolutely no problem. But unfortunately, it has to be done lifelong. Earlier, there was thinking that if self-calibration is done for 2 years, there is sufficient epithelialization and you can stop doing it after 2 years. But unfortunately, the recurrence can occur anytime. And it's better to start doing it or continue with it lifelong. The first step is to pass the guide wire. Keep pushing the guide wire and then taking the scope off. So then with the cold knife, you cut at 12 o'clock position. Close the hand. Important to cut only in the scar tissue. These white things are the scar tissue which needs to cut. And it should not be very cutting. Now we've gone into the bladder. Okay, now we can take the guide wire. Bladder, you change the guide wire so that sufficient part is inside the bladder. More wide. Once you're confident that you're in the bladder, the guide wire. And if it doesn't go, you can put both the guide wire and the catheter together. But this is gone. Fine. वही तरह से दूसरे तरह देना चाहिए. What stricture is that? Because it's a circular tissue. Once you cut, when healing, stricture will reform. So to prevent it from reforming, you need to do self-calibration. So here, what was initially just enough to pass the tip of the guide wire, now it's been cut so that 20 French catheter goes easily. And of course, as with any surgery, there could be complications which need to be explained to the patient. It occurs in 6.5% of the people, especially if you're not able to cut properly and put in a proper size catheter. This can be in the form of incontinence, extravasation, hematuria, and abscess, and so on. And even though this has been there for a very long time, the newer treatments consisted of stents, which are not very successful. Then people have tried injecting steroids or mitomycin C in the strictured area, which again is helpful a bit, but not extensively helpful or remarkably helpful. So it's not very commonly used. And of course, the latest trend is to do a more expensive treatment like laser, which is almost similar to the traditional EIU or a cold knife, this thing. What about open surgeries? At one point in time, because of the so-called higher recurrence without self-calibration, but there are many open surgeries, which included stage procedure. You later open, and then once there is sufficient blood supply, maybe 6 months or 1 to 2 years later, then you reform the tube. Grafts from foreskin or buccal mucosa were used, and then there's end-to-end anastomosis and so on. But these are not very successful. But what is most important is the post-operative advice which you give, which is daily self-calibration. So usually when it's patients would like to know how long you have to do it. So if you say lifelong, they'll be sort of put off by it. So we generally tell them, do you brush your teeth daily? And are you planning to do it lifelong? Then they will understand that it's almost like brushing your teeth, something that you do regularly. So we advise them they should do self-calibration while they're having a bath, where there is enough privacy, it's clean. But the important thing is that they need to use a catheter which is absolutely dry and clean. And there should be sufficient self-calibration. And the most important thing is that after you do the procedure, you should empty the bladder, because whatever bacteria, everything which went into the bladder, you will empty. So if you do this, this is the ideal treatment for strictures. Thank you.